Hi, everybody. Welcome to the final week, which is very exciting. This week is so big, so the slides aren't that pretty enough time, right, to make 1,000 slides. But we have pharm going through inotropic, which is relating to heart failure, lipid lowering, which is relating to a lot more risk factor sort of things like atherosclerosis, anti-arrhythmic, which is relating to the kind of beating of the heart. And we'll do physiology, a very small amount on venous return, a very large amount on endothelium, which isn't too high yield, and some HEP. So to begin with, we'll start with inotropic agents. And I put this first because other than arrhythmias, this is the hardest or second hardest one to go through. So the first dot point of this lecture was to understand heart failure and the causes of heart failure. So when we think about heart failure, it's a subset of heart disease. And we've encountered quite a few heart diseases, and the one we're going to talk about today is heart failure. This image is just showing one type of heart failure with dilated ventricles, but there are several types which we'll talk about in a moment. The major causes of heart failure are ischemic heart disease. This is primarily due to the fibrotic deposition that interferes with the heart's ability to fill and pump. Cardiomyopathy dilated, don't need to know what that is, don't worry about it. And hypertension is a big risk factor because it puts a lot of stress on the heart, and eventually the heart can't deal with that amount of stress. So we've got some clinical features of heart failure, which hopefully you've encountered in clinical skills. Just give me an indication if you have, so I know how much to explain. You have, wonderful. So what's really important about heart failure, and you might not have known from clin skills, is that left heart-sided heart failure and right-sided heart failure are a little bit arbitrary. As you know, they're all in the same circuit, and so heart failure of the left side will almost really, really often affect the right side, so often the symptoms overlap. And if you look in a lot of textbooks, the symptoms are given together. So this is from a textbook and the symptoms are given together, but I've color-coded it so that it's for your buzzword information. So if we look at symptoms, these red is for left-sided heart failure. You have exertional dyspnea, which is shortness of breath on exertion. That's because when you exert, as you remember from before, hopefully, if you don't, it's okay, you require a great amount of cardiac output to go to primarily your skeletal muscle. And sometimes that's just too much for the heart to handle, so it can't perfuse all that blood. Orthopnea is shortness of breath lying down. That's primarily due to if you have a lot of fluid in the left ventricles, it backflows into your pulmonary circuit, and then you have fluid in the lungs of your pulmonary circuit, which makes gas exchange difficult to occur, and you'll have shortness of breath. Paroxysmal nocturnal dyspnea is when you wake up in the middle of night, short of breath, gasping for air, for similar reasons to orthopnea. These two are relating more to pulmonary edema, lung edema, fluid buildup, exertional dyspnea more to the cardiac output. On our right side, when we listen to our lungs, we'll hear crackles due to the fluid buildup, and there'll be pleural effusion present as well, possibly, but not as significantly as the others. Right-sided heart failure, primarily the signs are increased edema in the systemic circulation. So you have an elevated JVP, peripheral ankle edema that can go up to your sacral edema, and you have some ascites. Ascites can also occur, like we talked about last week in Andrew's presentation, if you have a lack of protein being produced in the liver, for example, albumin. So because of the osmolality difference, the fluid flows out into the interstitial tissue. There are two primary types of heart failure, acute heart failure and chronic heart failure. And because of just really rapidly developing treatment, the amount of acute heart failure is declining and the amount of chronic heart failure is increasing because people are going to live longer. Acute heart failure often follows a precipitating event, such as an ischemic event, which leads to a fibrotic buildup, whereas chronic heart failure is more divided into two forms, a systolic dysfunction and diastolic function. We'll see an image of these in the next slide, but a systolic function is when you have impaired contraction, and so you have your reduced ejection fraction, which is your systolic volume divided by your end diastolic volume. In other words, the amount of blood being injected is reduced due to an inability to contract, whereas diastolic dysfunction is when your contraction is completely normal, sometimes even increased, but you have impaired filling. And so you have the same amount of ejection fraction, but the filling is reduced. This over here is talking about some of the left and right-sided heart failure symptoms from before. I think we've described this. This liver congestion can cause episodies, as we've called. So this is a good revision slide if you would like. So this is just showing you those differences visually. We have in the top column the pathophysiology following. This is all from the clinical medicine textbook. I think it's Katsun. If you text me, I'll send it to you. Clinical medicine textbook. This is a pathophys. So you have ventricle remodeling after an acute infarction. You have your infarction. If you remember, usually it's an occlusion of a coronary vessel leading to infarction or decreased blood supply and tissue death of the tissue area supplied by that vessel. That infarction can expand, and eventually a fibrotic remodeling can lead to a heart that looks like this. So you have damaged muscle, you have fibrotic tissue inside of that cardiomyocytes, and so as a result, you have impaired ejection. On the bottom, you have your more common chronic heart failure, and this is due to ventricular remodeling. For comparison, this is a normal heart. In a hypertrophied heart, you have because the heart is working really hard to pump a lot of blood. So for example, in hypertension, if you have a lot of peripheral resistance, the cardiac output demands is quite high. So the heart has to pump really hard. And because the heart is pumping so hard, it hypertrophies because it's such a high metabolic demand. And as a result, you actually have less space for the ventricle to fill from the atria. And as a result, you have a heart failure with a preserved ejection fraction. So the muscles are fine, you just have a diastolic dysfunction. When we look at our systolic dysfunction, we have heart failure with a reduced ejection fraction. This sort of heart failure is due to a reduction of the muscles in the cardium, in the heart cells, and as a result, the heart can't contract as much, and so you have a reduced ejection fraction, which again is your systolic volume, or the volume of blood pumped out each pump, over your end diastolic volume, which is the amount of blood in the ventricles. The heart, in order to compensate for these changes, often has some reflexes. So in the process of heart failure, when you have a reduced cardiac output, either due to reduced filling or reduced ability to pump, the sympathetic system can activate to increase the work of the heart. And this functions in two ways. One of the ways it functions is by affecting the preload. The second way it functions is by increasing the afterload. By increasing the preload, it increases filling that can stretch the heart muscle like a balloon, and the attempt to cause increased cardiac output. But if you can remember, some of these, when we mentioned the Frank-Starling mechanism, there was a peak. And when you were stretching it further to that peak, the heart couldn't pump as much because it was just the muscles were just being stretched too much to have optimal contraction. And sometimes that can occur. Sometimes your increase in preload can stretch the heart too much to the point it damages the heart further. Furthermore, with that concept, heart stretch too much, there's also fibrotic tissue, which means it can't stretch as much anyway. So you're really putting a lot of strain on the heart by doing this sometimes, even though it's part of the mechanism to respond to it. The second thing that happens is due to that sympathetic reflex, you have a constriction of arterioles, which increase afterload. This is often mediated by alpha receptors in the peripheries, and this strains the heart even more because you need a greater cardiac output in order to overcome that afterload, and that means the heart has to pump harder. And often the pumping harder can lead to more hypertrophy, or it can damage the heart. This is because afterload increases, larger cardiac output is required. So a really important concept of heart failure is that the normal reflexes, physiological reflexes to counteract it, can actually make it work. And so that is why you have a steady state of decline in chronic heart failure, and why acute heart failure can progress to chronic heart failure, and why left-sided heart failure can progress to right-sided heart failure, and furthermore, quite a poor progression. So if you have a reduced end diastolic volume in diastolic heart, you have reduced stroke volume, reduced cardiac output, but a preserved ejection fraction. In systolic, you have loss of contractility, and as a result, you have reduced ejection fraction. In ischemic events, you have fibrotic deposition, and that stimulates heart failure because the heart loses capacity to contract, and it can't, when it's filled with fluid, it can't compress as much it can't dilate as much through that Frank-Starling mechanism to dilate to eventually contract. This here is just a summary, once again, of left-sided and right-sided heart failure for your reference. You can imagine if they are having struggle pumping fluid through here, it's going to backflow through the lungs, which is going to backflow through the right system, which is going to backflow through the systemic system. So often these can occur all together. Now we're actually going to talk about the pharmacology of it, which is really our next stop point. So in everything Katja and I are going to talk about today, the main treatment is usually lifestyle. So usually it's going to be like controlling hypertension, controlling hyperlipidemia, I'm trying to exercise more, eating healthier, those sort of modifications. The next part of treatments are quite pharmacological, and there's two kind of thought processes in treating heart failure. The first is to decrease cardiac workload to reduce strain of the heart so the heart failure doesn't progress. To do this, you use these drugs, ADB or ABT, but the reason why you've put it in ADB is because these are usually the orders you give it in. But yeah, so you have an angiotensin and a RAS inhibitor, a diuretic and a beta blocker. And I'm fairly certain that these two will be unfamiliar to you because you'll learn about them next year, but you do need to know have a bit of a tertiary understanding, at least some examples of these drugs. So if you think about it, the one way we can combat heart failure is to reduce the stress of the heart so it doesn't progress. The other way we can combat it is assist the heart so it doesn't have to work as hard, so increase contractility. And these are through the involvement of positive inotropes, such as digoxin and dibutamine. Digoxin is very important, and this lecture is on inotrope, so this isn't a very important section that we'll come to. This is just, it's quite intimidating. It's a treatment summary from a textbook. You definitely don't need to know all of it, but it's just showing you start with risk factor education. You treat hypertension, dyslipidemia, diabetes. Then you'll consider ACE inhibitors and maybe beta blockers, depending on age often. And you'll just progress up this ladder with drugs to do the best you can. So the first thing we're going to talk about angiotensin. And this is going to be quite complicated for you because you don't know how the kidneys work, but we'll do our best. And really all you need to understand is that angiotensin 2 acts on angiotensin receptors. And when they act on angiotensin receptors, they lead to vasoconstriction, which increases afterload, and salt retention, which increases the fluid in the body. If you remember, in heart failure, peripheral resistance is contributing to our decline of cardiac function. So this vasoconstriction is worsening the cardiac failure. And there's too much fluid buildup in the lungs or peripheries, giving us our symptoms and signs. So retention of water is problematic. Remember, the salt will follow the water through those bonds. This is a diagram. I really don't think you need to know how it works, but maybe just know ACE inhibitors convert angiotensin 1 to angiotensin 2, and angiotensin 2 acts on AT1 receptors. The drugs we're going to talk about today are block ACE inhibitors, so you don't get the angiotensin formation, and the other ones block the receptors themselves. So yeah, as we said, angiotensin 2, so if you give ACE inhibitors, by blocking angiotensin 2 or giving an ACE inhibitor, you lead to vasodilation, a reduced peripheral resistance, and a less cardiac output demand on the heart, so it undergoes less strain. And increased salt retention leads to more fluid, so if you block it, you have increased secretion through urine, and you can clear the lungs and the peripheries and that edema. This is very important. ACE inhibitors, the suffix of these drugs are pril. When you take histories, a couple of the drugs that people say they have would be enalapril or perindopril most often. Just remember, suffix pril is ACE inhibitors. Most important part of these ACE inhibitors, I would say very high yield is their adverse events. So the angiotensin 2 or the blockage of angiotensin 2 through ACE inhibitors leads to an increase in a substance called bradykinin, and bradykinin causes dry coughs. And a big reason often people can't tolerate ACE inhibitors is because of this dry cough. This is a very high yield concept. Some other adverse events of ACE inhibitors is they can lead to hypotension. If you imagine you're urinating all your fluid out, so you can have a decreased volume of blood. So you want to be careful of that. And furthermore, if you're decreasing all the water, you can lead to hyperkalemia. So that's quite dangerous, and Katja will talk about the effect on arrhythmias. But potassium is very, very important. When you think of potassium, you should think of arrhythmia. It's contraindicated in pregnancy. So it's quite important. You can't give ACE inhibitors to pregnant people. Angiotensin receptor blockers. The suffix of these drugs is sartan. Remember the suffix of ACE inhibitors, pril. Suffix to these is sartan. They target the receptors directly. So while they have the same effect as ACE inhibitors, they don't lead to that bradykinin release. And so you don't have that dry cough. So they're often indicated in people intolerant to ACE inhibitors. Now we're going to mention some diuretics. Quite important concept that's quite confusing. You don't need to know all of this. This is in the lecture. This is here to scare you, I'd say. Don't take too much attention to that, but all you need to know is a diuretic increases water and sodium excretion from the kidney to decrease the volume of blood in circulation to resolve those edema symptoms. It can reduce fluid in the lungs, and that's important because you can't breathe because of the fluid in the lungs. So that's an important thing to fix. This is a kidney tubule. In the kidney, the fluid's going to flow through here, down here, down here, down here. And you have little channels in the kidney that facilitate what comes in and out. If you give loop diuretics, they're blocking sodium coming out at this point in this loop. You don't need to know what it is. Blocking sodium here. That means the water is going to be retained. Thiazides are blocking sodium coming out here, which means sodium is being retained. And our potassium-sparing diuretics are blocking sodium. Sodium coming out here. So all you're doing is blocking sodium coming out. The most important drugs for you to know is loop diuretics and furosemide, also known as Lasix. That's probably the most important diuretic. It's given to take the fluid out of the lungs very commonly. It's very efficacious, so it's given first line, usually in preference to thiazides, sometimes with potassium-sparing diuretics, but you don't need to know that. Just know loop diuretics, furosemide, you need to know. Thiazides, often in thiazide, which makes it a bit easier. They act at the distal tubules. You don't need to know them as much. And potassium-sparing diuretics. As you can imagine, if you're giving these diuretics, you're going to lead to a lot of fluid loss, and that can lead to a lot of potassium leaking out. So you can have hypokalemia. This drug, potassium-sparing diuretics, allows you to still have to retain the potassium so you can maintain electrolyte balance. The main one is furosemide. It's indicated to resolve edema. It inhibits sodium reabsorption. It reduces blood in the circulation, which reduces pressure in the capillaries, so there's less leakage into the interstitium. Loop diuretics are given over thiazides often, just because they're more efficacious immediately. And adverse events are hyperkalemia. Potassium is involved with arrhythmias, Katya will discuss. And interaction is often used in combination with other drugs. So it's often used in combination with other drugs, and it increases digoxin activity, which we'll talk about. Toxicity, sorry, which we'll talk about in a moment. Potassium sparing are just diuretics that can be given to prevent hyperkalemia. All you need to know. Now we're going to talk about a drug class called beta blockers, which hopefully you're the most familiar with. They decrease sympathetic action on the heart. The mechanism of action is quite unknown relatively. They could have anti-arrhythmic effect, could have anti-ischemic effect, could have reduced catecholamines. Remember, catecholamines are like your noradrenaline, adrenaline, and it can reduce the toxicity of those. It's not really sure. Another theory that I thought may be connected here, I think I saw somewhere, is that when you decrease the heart rate, if you remember from our cardiac cycle lecture, the diastole decreases by a greater rate than systole, but your coronary arteries are filled and perfuse the myocardium during diastole. So you have a greater period of perfusion of the myocardium and filling of the coronary arteries with these beta blockers. But they're unlikely to ask you their mechanism of action just because it's quite unknown. You need to definitely know what the drugs are. The drugs are propranolol. Propranolol is non-selective, blocks beta-1 and beta-2 adrenoceptors. Does anyone remember where beta-1 acts and where beta-2 acts? Shouts. Oh, sorry, you've been asking questions and I haven't seen them. What's preload and afterload? Is what is in the tube, the urine, heart, lungs? All good questions. Oh, well, one good answer and the other two good questions. What is preload and afterload? I'll just go back to that quickly. All preload is preload refers to the filling of the ventricles with, let's take this normal heart. Preload is the filling of that ventricle with fluid. And the more you fill it, the heart is like a balloon. The more it stretches, the more it can compress. So that's all preload is. If you increase preload, you increase cardiac output or the amount of blood going out. afterload refers to peripheral resistance. So if you have constricted arterioles, that increases resistance in the circuit or the system of blood flow. And so your body compensates for that by increasing cardiac output. Is preload the same as end diastolic volume? Yes. So they're the same. End diastolic volume is what leads to preload. Preload is like a pressure, end diastolic volume is the filling of the fluid. But yeah, and if you increase end diastolic volume, you increase preload. It's not as venous. So end diastolic volume is determined by venous return. Sorry, the question is preload the same as end diastolic or venous return? It's more related to end diastolic volume, I'd say, because it's related to the filling of the ventricles and that compression. Venous return often directly determines end diastolic volume. So some textbooks would say preload is related to venous return, but we're all just saying the same thing, which is they're filling the ventricle up with fluid so they can compress harder. Does that make sense, that preload afterload question? So when we decrease afterload, we're decreasing the cardiac output the heart needs to pump against. And when we're decreasing preload, in the case of heart failure, preload's a little bit different because the heart doesn't have that. Sometimes it's fibrotic changes. Sometimes you're pushing the heart too much. We don't want to increase that cardiac output. We want to reduce it. But afterload is the main mechanism of making heart failure worse through that sympathetic system. Does that make sense? The person who asked that? Hopefully it does. Is what is in the tube the urine? So the tube, yes, awesome. The tube, you really don't need to know this, but where did it go? Yeah, so all the fluid is being filtered through the kidneys. It's the water, sodium, all your electrolytes are thrown through here, and then it's going to go to your ureters and through your urethra as urine. Yeah. Good question, don't need to worry about it. But yeah, this is what makes urine, the system. And if this works really well and you take all of these out, you're going to have more like yellow colored urine because there's not much water. But if you don't have these coming out, you're going to have quite water colored urine because there's more water. Don't need to worry about that. Ignore it if it doesn't make sense. Sorry, I didn't see your questions. They were on a hidden tab. Decrease heart rate. Yep, up to that. Beta blocker, someone answered that. So propranolol works in both. You would not give these in asthma, as you know. Cardioselective is atenolol, blocks mainly beta-1 adrenoreceptors. They have adverse effect. They can lead cold extremities, which is particularly important in Raynaud's disease, provoke asthma by activity on beta-2 adrenoreceptors. Remember, both beta-1 adrenoreceptors, beta blockers and beta-2, beta-1 beta blockers and beta-2 beta blockers can't be used if someone has asthma. They're contraindicated because even though it's cardioselective, there is a slight cross-reactivity, unfortunately. And really important is beta blockers can lead to heart failure in too much doses. So you've got to dose very carefully, low doses initially and increase doses slowly. Almost done. Wow, this is quicker than I thought it'd go. So we have positive inotropes. Most important drug to know here is digoxin. And it works by inhibiting the sodium potassium ATPase. It's quite a few questions on this. I don't remember if they're in the exam or in revision, but quite a few questions on this. The reason why this leads to increased contractility of the heart is when you block the sodium potassium pump, you have an increased sodium, and that means that the sodium calcium channel increases more. This is a bit of a confusing thing, but what you're having is calcium going in, sodium going in as well. So calcium goes in with sodium. This is such a stupid diagram. Is there a better diagram? There's not. So this blocks sodium, so there's lots of sodium here. The calcium goes in with the sodium. Let me draw it. Oh, you can see my mouse. Sodium goes in this way. Calcium goes in this way. If you have a lot of sodium, you're having less sodium coming in, and you have less calcium coming in. When you give the blocker of this channel, let's find a better diagram, because why are there 2 arrows on that? Katja, do you mind just getting it'll come up pretty quickly if you just type in digoxin?
Yeah, we'll do.
And then we'll work through that. So it inhibits the sodium potassium pump and increases intracellular calcium, which is what leads to increased contractility. And because you have increased contractility, you don't need that oxygen, as much oxygen demand. So there's less oxygen demand for the same amount of contractility, and ultimately that increases cardiac output. So if you can remember, this is a different approach. Instead of reducing the stress of the heart, we're making the heart beat faster for less effort, or harder for less effort. It's indicated for patients who are symptomatic despite the use of all these other drugs we've discussed. Its adverse events are quite significant. High doses can cause ventricular arrhythmias, which can be fatal. It leads to GI disturbances, nausea, agitation, and visual hallucinations. It has a very low therapeutic range. Yeah. Okay. Significantly, it has a very narrow therapeutic range. So it's toxic, very easy to get to toxic doses. It has quite a long half-life. Some reason they ask a lot about half-life of drugs, and quite a large. How does digoxin cause decrease? Okay, all good. How does digoxin cause decreased oxygen demand? It does that because in order to, so all you need to know is if you block this pump, you have increased calcium. If you have increased calcium, it's contracting much easier. So there's not as much strain on the heart to the heart is working harder with less need for supply. You give digoxin to have an abnormally large amount of calcium in the cells, which means the heart pumps way easier and way larger. And it doesn't require necessarily more oxygen demand to do this. It does it due to the calcium. Why were the nitro vasodilators we talked about contraindicated in heart failure? It's a good question. You would think that because it reduces afterload, it would be good. I think it's probably to do because nitro vasodilators substantially increase preload. I'm not sure though. So the question is, why were the nitro vasodilators we talked about for angina contraindicated in heart failure? I don't know the answer to that question. I'm sorry. I used to know the answer to that question.
Maybe it's just to do with the blood pressure?
Potentially, probably.
Because I know you can't use them for like hypertension, right?
Not sure.
Mm.
Yeah, I'm sorry. I don't know the answer to that question. I don't want to make anything up. Good question. But yeah, that's important. So nitrates are really only indicated for angina and hypertensive crisis, isn't it? Yeah, angina and hypertensive crisis. Those are the only indications. I don't know why they're not indicated. Another question is, why is calcium not indicated here? Calcium channel blockers. And I searched that up, and that was just because of the results of a study. Like a lot of this isn't through theory. A lot of it is it makes sense this might be able to work, and it just doesn't. It increases mortality. So calcium channel blockers also increase mortality in heart failure, just because they really reduce the functioning of the heart quite significantly. There's no in between. But yeah, that theory would be confusing, but the reason it doesn't work is because of the studies that say it doesn't work. Great questions. Yeah. Where were we? So it's quite lipophilic drug. It has a very large volume of distribution, which means it's going in lots of different compartments of the tissue. It has reduced clearance in renal dysfunction. So you have to be careful of people like kidney failures. Elderly people often have impaired kidney function. Toxicity is increased by electrolyte disturbances. So if you have low potassium, especially because you're blocking the sodium potassium channel, so you really may not have enough potassium in the cells, and that can lead to arrhythmias if you have really low potassium. And a rise in calcium levels can lead to calcium overload. It interacts with diuretics because they also decrease potassium levels, so you've got to be careful. The last inotrope we're going to discuss is a beta-1 adrenoceptor agonist. Last year when I was learning this, I didn't think this was important, but it came up relatively often, so maybe do know it. It's called dobutamine. It's a beta-1 adrenoceptor agonist. its mechanism of action is just to increase contractility, which increases cardiac output. But really, it's not super effective. You can only use it in the very short term because the receptors desensitize and get internalized. And yeah, you got to be careful with beta blockers, and using this together will cancel each other out. So this is working to increase contractility to help the heart pump. Beta blockers is using to reduce the strain of the heart so it doesn't progress. So it's very fine balance in between making the heart failure worse and helping the heart, which is mostly experimentally discovered. This is just a summary going through the tables. First, we're restricting our diet and weight control, controlling our risk factors, then often a diuretic or ACE inhibitor. Which one you give is often dependent based on age. Then you can combine different classes, swap within classes. You can add digoxin if you need and add a beta blocker or a potassium sparing drug. I'm going to give one more presentation on lipid lowering drugs. This one's a little bit easier. And then Katja will give a presentation on arrhythmias. This is a tough week. It was tough to make these slides as well. So yeah, hang in there. So hyperlipidemia is really a condition. It refers to when you have either high cholesterol or high triglycerides. What you need to know is it refers to when you have high cholesterol or high triglycerides, which is hypercholesterolemia and hypertriglyceridemia. These in themselves aren't like super dangerous. They don't like often have clinical syndromes you can see, but they're significant risk factors for a lot of cardiovascular disease. Hyperlipidemia can be caused primarily just because someone has a lot of cholesterol and a lot of triglycerides, just like because they do, because through their diet or through their genetics, or through their diet mainly, and lifestyle. Secondary, and of course, genetic will have a contribution to that, but that's primary cause. Secondary cause is usually due to another disease, so like thyroid disease. You can have high lipidemia. Some drugs lead to high lipids, high cholesterol, and diabetes. So you should know primary is high cholesterol or high triglycerides. Secondary is if you have hyperlipidemia because of a disease or a drug. Often they'll characterize mental illness by the same thing. I don't remember if you do that in psych in first year in mum, but primary is if you just have those symptoms. Secondary is if you have, like, for example, depressive symptoms because of a disease or a drug. So this is a useful differentiation. This is a scary overview. I'll just give you a bit of an idea of where we're going. You can reduce the amount of cholesterol or lipids you have through a lot of different mechanisms. You can reduce the synthesis of cholesterol. You can do that by blocking this enzyme, which leads to the synthesis of cholesterol. You can do it by, where should we go next? You can do it by interfering with lipoprotein lipases. So if you block lipoprotein lipases, you don't get the distribution of much fatty acids. So that doesn't occur. You can do it by blocking the reabsorption of cholesterol back into the liver for resynthesis. And you can do it by interfering with LDL receptors and decreasing the secretion of chylomicrons. So we'll go through each of those here. I think this diagram is a bit more digestible, but we're going to start with statins, which are the most important effective drugs involved in hyperlipidemia. The suffix for statins is statin, which is wonderful. Atorvastatin is probably the most common one you'll see around in exams, at least. And their mechanism of action is they're an HMG-CoA reductase inhibitor, So here you can see acetyl-CoA is being converted to HMG-CoA. HMG-CoA is being converted to cholesterol by this enzyme. When we inhibit, we get less production of cholesterol, which is used in packaging VLDLs and transport around the body. When you reduce cholesterol, you increase LDL receptor expression. That's like often a mechanism. If you increase neurotransmitters, hormones, the receptors for those hormones will increase as a compensation in order to maintain homeostasis. But because your increased LDL receptors occur, you're increasing LDL plasma clearance. So you're taking LDL away from the plasma to bind that LDL receptors, which are depicted as B100 and this LDL. That's what this is showing, being internalized and recycled. It's indicated in primary and secondary prevention of cardiovascular disease. Next drug that's the most important drug of the lecture. Next drug we're going to talk about fibrates. These aren't as important. They're getting a little bit dated, I believe, but I'm not 100% sure. They involve the upregulation and stimulation of lipoprotein lipase. So they decrease the production of VLDL and increase the hepatic LDL uptake. And their function mainly is to greatly reduce triglycerides. They're indicated in hypertriglyceridemia and mixed hyperlipidemia. You don't need to know them too well, I would say. I don't know, Katja, what do you think?
Yeah, you're good. Just maybe have a basic understanding, but than that, it really doesn't come up.
Yeah. So they enhance lipoprotein lipases in order to reduce the amount of circulating chylomicrons. But yeah, I don't remember seeing this come up, to be honest. Bile acids, this is just some context for the next thing. They're formed from cholesterol in the liver, and they aid the dietary absorption of fats. So cholesterol is converted to bile acids in the liver. It's transported to the gallbladder. When you have fats, it's going to be ejected into there to help digestion of the fats. They get reabsorbed and cycled in the ileum, which you don't need to know what that is yet. So some drugs act by binding bile acid, and by reducing the amount of bile acid, you don't have the same amount of absorption as fats. That decreases. So you have cholesterol and cholestyramine. When I said fibrated, I say they enhance or reduce lipoproteins. They enhance lipoprotein lipases. I hope I said that, to reduce the chylomicrons and LDL. Yeah, just clarifying that. I don't know what I said, but that's the answer. So bile acids bind this. They decrease absorption of exogenous cholesterols, and they increase, as a result, the metabolism of endogenous cholesterol to bile salts. So you're reabsorbing the cholesterol, so it's not circulating by any of your endothelium and contributing to atherosclerotic plaques. You have decreased cholesterol in the hepatocytes, and as a result, compensatory increase in LDL receptors, which is going to mean you have a greater internalization of LDL, indicating hypercholesterolemia and mixed hyperlipidemia. Cholesterol absorption inhibitors. Look, so the resins here, this is our ezetimibe for our cholesterol absorption inhibitor. This just, as the name says, it inhibits the absorption of cholesterol. So it reduces the amount of LDL levels. That's its primary clinical effect, because if you have a limited amount of cholesterol in the peripheries, you have more LDL, and that's going to take even more of the cholesterol, of those LDL circling around. If you have more LDL receptors, more is going to be internalized. It targets this transport protein. Probably don't need to know that too well. And yeah, it's the reason why I said, like, you don't really, yeah. They kind of are a little bit better than resins, essentially. They have a higher potency. They're effective in absorbing, and they're effective even if you don't have dietary cholesterol, because they internalize endogenous cholesterol, and they inhibit reabsorption of cholesterol in the bile. So if you secrete your cholesterol and it gets reabsorbed, this stops that even endogenously. So you're reducing cholesterol whether you're consuming a lot exogenously or not. These are less significant. You have niacin, which inhibits VLDL secretion from the liver, which is that chylomicron that deposits fats and cholesterol over the body. It decreases LDL levels as a result of that, and often increases HDL levels. Fish oil is protective against cardiovascular disease and lowers triglycerides. This is a new drug called PSK9. It targets LDL receptors. It promotes lysosomal degradation and decreases LDL recycling. This means there's increased circulating LDL as the amount of LDL receptors take. So all it does is this is an image of it. It's where do we start? We'll go here. It goes onto that LDL receptor, and as a result, that LDL receptor degrades. And yeah, that's essentially how it works. It also, yeah, this is just showing that there can be antibodies to it as well. Okay, so I feel like that was a bit muddled, so we'll do that again. PSK9 is an enzyme that goes to LDL receptors that degrade the LDL receptors. We want to reduce the amount of circulating LDL in the body, and in order to do that, we need to enhance the expression of LDL receptors. We enhance the expression of LDL receptors by having antibodies that target this enzyme, that promote internalization. If we block internalization, we're removing LDL from the circulation. Yeah, I hope I'm getting a bit muddled today. I'm sorry about that, but I think I've corrected every mistake, so hopefully that's okay. This is just a summary of, this is a summary for your reference. Thank you to that person. This is a summary of, just for your reference, to see how these different drugs work: blocking cholesterol absorption, blocking recycling of bile acids, blocking release of VLDL, blocking production of cholesterol. This is a bit more intimidating, but it's showing you the same thing. Resins binding to bile acids, so they're all fecally eliminated, so it's not recycled into cholesterol. Ezetimibe reducing the absorption of cholesterol, and it works with exogenous cholesterol and endogenous cholesterol as well. Enhancing lipoprotein lipases that lead to more formation of free fatty acids and less VLDL and LDL circulating in the systemic circulation to lead to buildup of plaque in endothelium cells. Fibrates that are decreasing secretions of VLDL, is their primary mechanism as well. Statins, resins, fibrates increasing uptake of VLDL by leading to an upregulation in LDL receptors to be internalized and recycled, and statins decreasing the synthesis of cholesterol. This I found, for this you really just need to know the drug names and what they do. It wasn't too much. This is just a comparison of how they work. Statins really significantly decrease LDL by targeting the cholesterol. Fibrates really significantly decrease tags, and nicotinic acid decreases the bad stuff and increases the good stuff. Again, this is a summary slide for your reference. What I might do now is I'll pass over to Katja.
Sure, doing well, guys. Just hang in there. It's last week, and I'll try to wrap it up. David kind of went through, I probably argued, the more challenging bit for today. So hopefully my bit should be a bit easier, and then we'll go back to David, I'm assuming, for the other stuff. All right, I'll just share my screen. I will be going through the very last of the pharmacology, the anti-arrhythmic drugs. Similarly, relatively low yield, as in you have to know like the key drugs, what class they're in. So like if they're like a beta blocker or a calcium channel blocker, and maybe like one or two of the adverse effects, but then that's really not too much to know from here. So hopefully by now you have a good understanding of how like the normal heart kind of structure works, and your PQRS and your ECGs. So arrhythmia is any abnormal pattern related to the heart beating. So it could be beating like too fast or too slow, those count as arrhythmias, or they could be beating irregularly, so not like on a steady kind of stable pattern. In terms of cardiac arrhythmia, generally they like to categorize it either by like location or speed. So for location, we have the atrium or the ventricle. Your big one for the atrium is atrial fibrillation. If you only remember like one condition from all of these arrhythmias, highly recommend going for atrial fibrillation. It comes up all the time. It's incredibly common, and it's associated with like heart failure and stroke because it's like kind of pumping irregularly. A lot of the blood can start like pooling at the bottom and can form clots, and people get strokes from that. The other one location obviously is your ventricle. I'm going to ventricular ectopics, which are just premature contractions. They go when they're not supposed to go, like kind of thing like an ectopic pregnancy, sort of. Ventricular fibrillation, which is really bad. If you get it, pretty much the person's flatlining and they're pretty much going to die. Like it's very rare to save someone from ventricular fibrillation. And ventricular tachycardia is the other common one. But yeah, just no AFib. So in terms of arrhythmias, we have kind of two things that can go wrong. The first thing that can go wrong is that the impulses that are being generated, like your electrical impulses, are being generated abnormally, like they're just not working the actual impulse. And then the second one is the conduction pathways. So hopefully you would have like, seen like how like the AV nodes, SA nodes, the Purkinje fibers, like that pathway, something's gone wrong over there. And now in relation to, so heart block, I just listed down here the first degree AV, second degree AV, third degree AV. Make sure you have like a good understanding of these, particularly the difference between first and second degree in terms of how you can spot it on an like ECG. because I remember it comes up a little bit, at least in the SIP, and I'm pretty sure the exam, or practice exams at least. So for first degree on an ECG, you have a prolonged PR. And then for second degree AV block, you have a P wave, but you don't have a QRS complex. So just know those. In terms of conduction pathways, you also have problems with re-entry circuits, which I have a slide on, but super low yield. I don't remember it's been tested at all. And you have a problem with after depolarizations. So I have a slide on those two as well. So this is an example of a re-entry circuit. And on the left is like a normal kind of conduction. It goes from the Purkinje and then goes like kind of down to the left and down to the right. And then for whatever reason, there's some kind of block that's happened, or a region where it's not reaching, so it starts conducting the other way. Don't really need to know this, but just since I had on the slides, I thought I'd have it up here just to explain it's to do with the pathways. EAD and DAD refer to after depolarization. So once the myocytes have depolarized, in certain conditions, they might depolarize again before they're meant to. So both early and delayed after depolarizations are actually both before they're meant to, like they both occur before they're supposed to happen. So your actual depolarization is supposed to happen like again later on, but early just means it happens a bit sooner, and delayed means it happens a bit later, but both of these are earlier than they should be. And that's just an example on kind of the graph on the left showing how, you know, early kind of depolarizes a little bit sooner, and delayed is a little bit later than early, but both of these are later than it should be, because it should be probably somewhere up here. The reasons why this might happen, particularly for delayed after depolarizations, is some drug toxicity. So digoxin in particular can cause delayed after depolarization. So it can mess a little bit with the rhythm of the heart. And you'll see that later on we'll discuss digoxin as a drug to use for arrhythmias. But if you use it in too high a dose, it can also cause arrhythmias in and of itself. Hopefully you're all familiar with the ions and where they happen. The way I've described these drugs in the next few slides is related to this graph over here. So this is known as like phase 4, phase 0, when sodium influx comes in, phase 1 and phase 2, when a little bit of potassium and chloride come out, not too much, but a little bit. And then some calcium comes in, and then a huge, now much bigger influx of potassium leaves the cell, and then it stabilizes down here. And these are where your main drugs work. So for anti-arrhythmias, we have 4 classes. We have a sodium channel blocker, and there are a couple of subtypes. We have a beta blocker, we have a potassium channel blocker, and we have a calcium channel blocker. So it's nice to learn these drugs in relation to like this graph, like when it happens, because that way you kind of only have to learn like one thing, like you learn the graph and I think, okay, well, no, I know class 4 acts on calcium, so it probably acts up here and stops calcium from entering the cell. So it's just, I found this a really neat diagram when I was studying, just to kind of like tie it all together a little bit. Okay, yeah, perfect. Kind of going over the same thing, except there was a very niche slide in the lecture series about hypokalemia and hyperkalemia. So I thought I would just touch on it just in case. Pretty much hypo and hyper can both in their own right cause arrhythmias. But if you had to choose one, you'd prefer hypokalemia. It's much better. Hyperkalemia, pretty much super bad, like a very dangerous position to be in. So if you ever see like an adverse effect of a drug being hypokalemia, it's bad, but like you might still prescribe the drug. If you see an adverse effect being hyperkalemia, you'd really think twice before prescribing it. So for hypo, you have some of your diuretics causing it. Whereas for hyper, it's some of the sartans that David just went through, your ACE inhibitors, and your potassium conserving ones. But you don't really need to know too much about this either, just know hyper is not great. And both of them can cause arrhythmias. So like I mentioned, these are your 4 drugs. Out of these 4, to be honest, class 1, I'd say class 2 come up a fair bit. Beta blockers come up in quite a few places, so it's nice to know those. Class 4 sometimes comes up for anti-arrhythmias, but class 3 very rarely comes up because it has so many other effects. So we'll go through them now. So these are just diagrams showing how the different classes affect your normal action potential kind of wave. But it's a nice diagram to look back after we've sort of gone through them. So I'll go through them first. So class 1 affects your sodium channels. Your sodium channels can exist in 3 forms. They can be resting, which is when they're kind of not doing anything. They can be inactivated, when they are doing something and they're letting sodium come in. Or they can be inactivated when they're purposely not letting sodium come in. So sodium wants to come in, but it can't. These drugs, these class 1 drugs, they work on those last 2 stages. They work on activated and inactivated, pretty much to support sodium not coming into the cell. And these are your 4 main drugs. They pretty much end in "ide" or "ine." So you have procainamide, quinidine, lignocaine, and flecainamide. These are split up based on their subgroups. So technically, like if you were in a textbook, you might see that first procainamide and quinidine called class 1A. Lignocaine is class 1B, and flecainamide is class 1C. That is way beyond the scope of year 1, probably beyond the scope of medicine. I feel like you very rarely have to know these like subclasses, but just thought I'd mention it in case you read a textbook and it comes up. So this is kind of the main drug that you'll see for class 1, but these other 2 categories can come up as well. So procainamide and quinidine, they slow the action potential and they prolong the QRS. And as a result of that, the person can develop lupus symptoms. So something to know with sodium channel blockers drugs, that the person can develop lupus-like symptoms. In lignocaine, your AEP is also shortened, but it also acts as a local anesthetic, surprisingly-ish. So because your AEP is shorter, it somehow manages to affect the sensation going in that area. So that's kind of an adverse effect to consider. And then in flecainamide, the AEP is unchanged. So unlike the previous 2, they alter the action potential duration. In the 3rd one, it doesn't. And it stops premature ventricular contractions. So if you have a problem with the ventricle that's contracting prematurely, so like maybe like a ventricular ectopic problem, you might go with that 3rd one. Our second class of drugs, which David has covered delightfully, is our beta-adrenoceptor antagonists. So just a reminder, this is your sympathetic nervous system. It synapses with acetylcholine onto a cell body, which then synapses with noradrenaline onto the beta-1 receptors in the heart. So B1, heart, because, well, the way I look at it is they have like one heart, so B1. B2 is kind of to do with like all your other airway muscles and all your other major muscles. B1 also works in the kidneys, but that's relevant for next year. So the reason why we think arrhythmias sort of happen, or partially the reason, is that there's overstimulation in the heart. So there's too much of this noradrenaline synapsing onto the B1. So what beta-adrenoceptor antagonists do is they bind to the B1 instead, stopping the noradrenaline actually binding. So by stopping noradrenaline, you're decreasing sympathetic drive to the heart, you're decreasing the sinus node automaticity because that increases with the sympathetic drive. And this is usually used in AFib just to help calm down the sinus node and calm down the contractions. It's also used after a myocardial infarction because it's thought to help reduce mortality if it's not spasming, I guess. And these end in olol. So these are your main ones, but pretty much anything that ends in like olol is a safe bet to be your beta drugs. All right, lovely. Class 3. Class 3 is a little bit funky. It's generally not kind of the first one you'd necessarily go to. You might start with the other ones and then go into class 3. The reason is class 3 has combined actions. So its like main action is blocking the outward potassium current, which happens in phase 3 of the graph. But that said, it also does some other things. So an example of a class 3 drug is sotalol, but that's actually also a beta blocker. So it also blocks potassium and it's a beta blocker. So it has a larger effect if you're looking for something specific, which is generally what you want. You want to be as specific as possible. It's not the best one to use. So the main one they would use is amiodarone, which is also a sodium channel blocker. So there you go. So it blocks sodium and calcium and potassium. So it has a lot of effects, which means it also has some serious problems like in the thyroid, lungs, and liver. So that's class 3. You don't really use it primarily. Class 4, calcium channel blockers. You have veramapil and diltiazem. I don't know how to pronounce that, but those two. Veramapil is like your more common one, I guess. And it blocks calcium entry, pretty much. Also used for AFib. But the biggest thing with calcium channel blockers is that you can't combine them with beta blockers. Because if you use both of them, they'll actually lead to heart block because their effects like too much. Because they both kind of work on like slowing down generation of the impulse. Digoxin, David also touched on this beautifully. Pretty much digoxin is like a vagal stimulation, so it helps slow down the heart. It slows down, it makes bradycardia, slows down conduction, but just be careful to keep it in smaller doses. In larger doses, it actually makes the heart more irregular. So small doses of digoxin is good. On this slide is sort of just like a summary of kind of the main conditions that your lecture went over. I would be sort of focusing on AFib, ventricular fibrillation somewhat, and bradycardia. Just a reminder for AFib, we also use anticoagulants because we're worried that because of the abnormal kind of impulses, blood's going to pool because it's not like pumping properly. So it's going to pool, and if it pools, it can form clots. And if it forms clots, those clots can travel around and like lodge in the brain. So a big one we use, in addition to digoxin or calcium channel blockers or beta blockers, we also use warfarin, which is an anticoagulant, stopping clots from forming. But yeah, I think that is it for me. Just a summary of all the cardiovascular drugs. Hopefully you have a vague kind of understanding of these. So just a reminder, know like the drug classes. So like your ACE inhibitors class, know like what they end in. So they end in like pearls, and maybe know like 1 or 2 of the adverse side effects. And if you know those, you pretty much should be good to go.
Thanks so much, Katja. That was really great. I'm just going to share something. So just the questions we had in regards to them. So how does digoxin work? You don't really need to know this, but it's just annoying me. You block the sodium potassium channel. That means less sodium is going out into that extracellular environment. If you have less sodium out in the extracellular environment, you don't have sodium to go in, and calcium goes out when sodium goes in. So if you have lots of sodium in here, this calcium doesn't go out, and you have an increased amount of calcium. The second question in regards to nitrates, I'm going to be honest, I don't know, and I didn't find a great answer on it. The question was essentially what Katja indicated, in that hypertension is the main contraindication. So in these 2 states, even though you have preserved ejection fraction, you have a smaller end diastolic volume, so you have less cardiac output, and so you could have low hypotension. In the dilated heart, you have reduced ejection fraction, so you can have hypotension. What I don't get and why I'm confused is hypertension is a risk factor for hypertrophied heart. So I don't know how long afterwards it changes and you get hypotension after a period of time. I think that's possible. And dilated cardiomyopathy is given as a risk factor here in this slide, but really a risk factor of dilated cardiomyopathy is hypertension. So yeah, I'm not so sure. I recommend ignoring it. But yeah, I imagine that maybe later you can develop hypertension and that's why you don't give nitrates. Not sure though. So what we're going to do now is we're going to go on to the rest of the presentation. Yeah, no worries. And thank you for the nice words, but we are not even close to done yet. No, I'm just kidding. We have endothelium and we have HEP essentially. So it won't be long. I'm going to go through the endothelium quite quickly because it is so low yield. It is almost scary. So endothelium is actually not that low yield. You should know it, but I can do it quickly. This is what a vessel looks like. You have endothelial cells between the lumen of the vessel and that identity between the lumen of the vessel, which is where the blood is flowing, and through the actual structure of the vessel itself. You have smooth muscle beneath this endothelial layer, which is part of this intima layer of the artery. What we're going to discuss now is this nitric oxide and what its function is. Endothelial cells are really important. They're not just physical barriers, but they also provide a lot of other functions. They contribute to vasoconstriction and vasodilation, as well as provide really vasoprotective factors from preventing coronary artery disease. They're semi-permeable as well, which allow the flow of substances from blood to tissue and tissue to blood. They also modulate thrombosis, which is coagulation, because if there's damage to the endothelium, it can trigger a coagulation cascade, which is mediated by the endothelium. Tell me about, if you want me to go fast or slow, it's not much. I was just being a drama queen before, it's not much. Contraction and relaxation. So acetylcholine acts on muscarinic receptors on blood vessels, and that facilitates contraction. So, yep, know that, acetylcholine muscarinic contraction. Most of this lecture is going to be about nitric oxide and its effect on relaxation or dilation. So while it does have that effect, it also has many other vasoprotective functions, such as antithrombotic, anti-inflammatory, anti-proliferative. And some of these are shown here. You see how nitric oxide is inhibiting adhesion of inflammatory cells, such as monocytes, and also preventing the activation of integrin, which recruits platelets and begins that coagulation cascade. The binding of all these substances to this receptor can trigger nitric oxide. Don't really need to know that. Maybe do know that shear stress or mechanical stress can trigger nitric oxide as well, and its effect of relaxation. Yeah, this is tough. You don't need to know it super well. Do know that there's three types of NOS enzymes. Don't know that. There's 3 types of NOS enzymes. The enzyme you need to know is eNOS enzyme, which is present in the endothelium, and it's involved in the synthesis of nitric oxide. So L-arginine is converted to nitric oxide and citrulline. The nitric oxide then diffuses across into this vascular smooth muscle and triggers relaxation. This is a calcium-dependent process. Nitrovasodilated drugs are indicated in angina and acute hypertensive crisis, which we actually mentioned before. So good foreshadowing, whoever asked that. And some examples of it are glycerol trinitrate, which is the main drug you need to know, often taken sublingually. Also can be taken transdermally, but often taken sublingually. Yeah, drugs can imitate the nitric oxide and diffuse across to the muscle. You can also have drugs that inhibit the action of nitric oxide by inhibiting this eNOS enzyme. I didn't know that last year, so I don't think it's important. Relax, there are other factors that relax other than nitric oxide. One of these is prostacyclin or PGI2. PGI2 is important in, so remember your prostaglandins, like PGE2 is important in inflammation. PGI2 is more about vasodilation and also like gastric acid secretion to maintain that part of the stomach, that environment. So prostacyclin also works as a relaxin factor. as does endothelium-derived hyperpolarizing factor, which is a bit of a mystery really what that is, but that's something that you should know, also relax factors. So nitric oxide mainly, prostacyclin has a function, and this EDHF does too. How important these factors are depends where you are in the body and if you're in disease or not. So over here, you can see this COX pathway is leading to this vasodilation by this prostacyclin. If you give a COX inhibitor, you can inhibit that. It's a vasoconstriction. Yeah, and then you have this enos pathway, which produces nitric oxide. Main two pathways, and these contribute to relaxation. We mentioned how sildenafil or Viagra also contribute to the CGMP that leads to relaxation, which is why you can't give sildenafil and nitric oxide or GTN together. There's different factors in different vascular beds. In larger vessels, you mostly have nitric oxide and prostacyclin. In smaller vessels, you have this thing called endothelium-derived hyperpolarizing factor, which is still quite a lot not known about it, but they know it exists. For now, the next point is talking about endothelium and disease. Endothelium dysfunction is associated with many diseases, such as coronary artery disease. And this is referring to the progression of atherosclerosis. Remember, as we learned before, atherosclerosis is an inflammatory process. And that inflammatory process, in a large part, is prevented by the action of endothelium and nitric oxide secreted by the endothelium. So nitric oxide prevents the adhesion of monocytes, which is involved in that inflammatory progress. Through this is describing the progression of atherosclerosis. If a monocyte does adhere to the integrins, can lead to an inflammatory process, engulf foam cells and contribute to a plaque. And as soon as you welcome, that's not the word. As soon as you sequester T cells, you further exacerbate the inflammatory milieu. Milieu just means environment. If you did, you might know that inflammatory environment within the vasculature, which is counteracting that effect of nitric oxide and is primarily stimulated by Th1 cells. Oxidative stress. So you might then ask, well, how does this happen then if you have your nitric oxide protecting all of this? And the reason it often occurs is due to oxidative stress. LDL can contribute to oxidative stress, which is why it's quite dangerous. LDL is a proatherogenic factor and can lead to the production of superoxides such as O2-, which is a reactive oxygen species. It binds with nitric oxides and reduces its bioavailability, means it's less available, so you have less of a protective effect of nitric oxide, which promotes atherogenesis. So you have less vasorelaxation and increased proliferation of the muscle, and there's a greater inflammatory process which involves the activation of fibroblasts depositing collagen. Endothelial dysfunction is also associated with hypertension. So remember, endothelial dysfunction is associated with atherosclerosis and hypertension, amongst many other things, but these are the two examples given. Nitric oxide is impaired in patients with hypertension, and an endothelial dysfunction as a result is a significant risk factor for cardiovascular disease. If you have impaired nitric oxide, you can lead to vasoconstriction and remodeling, which leads to vascular mousse cell hypertrophy. So over here, you can see your nitric oxide leading to relaxation. This is in a normotensive cell. This is in a hypertensive cell. You can see there's increase, like a muscle volume, increased hypertrophy, decreased vasodilation, increased vasoconstriction, inflammatory cells everywhere, less nitric oxide available, more fibroblast deposition. Nitrates and angina, we've discussed this. Nitrates result in the release of nitric oxide in vascular smooth muscle. Katja made a really good slide on this. So if you increase arterial dilation, you have reduced afterload. That means less blood is required from the heart to get to the muscles to perfuse them and substantiate the high metabolic demand. So just as a recap, angina is when you have occlusion of the coronary vessels. And in order to treat angina, we want to reduce the stress on the coronary vessels. So we do this by reducing afterload, which means less cardiac output is required, there's less metabolic demand, and so less oxygen is required from those coronary arteries. Furthermore, nitric GDN dilates coronary arteries, so you have increased oxygen supply, makes it a bit easier for them, and it reduces preload, so you need less cardiac output and reduced oxygen demand. So I can see why you'd be confused with, well, and why can't you give it in heart failure? And vaguely the answer to that is because you can't give it, it is not indicated, is contraindicated in hypotensive states. You can go too much, it's all about a balance. Endothelial derived constricting factor is a factor, now if we look at the other side, that is involved in constriction, thrombosis, and vascular remodeling. If you remember, if you have a cut, you vasoconstrict, you thrombose, and you vascular remodel. This is part of a healing inflammatory process, and it's really important. So while we've talked about how good nitric oxide is, when you're injured or cut, then this all is really important to making you heal. Endothelin, I would say, is the most important one to know of these vasoconstrictions. They're long-lasting vasoconstrictors. They potentiate the effect of other vasoconstrictive elements, and they stimulate proliferation. We remember before we said acetylcholine and muscarinic receptors, that's come up again. 5-HT is serotonin, don't really need to know that. Stimulates proliferation in this context. Stimulates proliferation and a blockage. So a treatment that exists is the blockage of endothelin. And as a result, that leads to increased vasodilation in patients with hypertension. So this is a slide on some drugs that block endothelin and increase relaxation. Almost done. This is a slide of everything together. We have our quite a complex slide. So this is our endothelin over here, potentiating and leading to vasoconstriction. Thromboxane A2 has occurred. It's an important factor in thrombosis. If there's a cut, something like that, leads to vasoconstriction and proliferation of muscles that have been cut and you need to replace. On this side, you have our enos enzyme converting L-arginine to nitric oxide, which contributes to vasorelaxation. Important is that reactive oxygen species can interfere with this nitric oxide release and decreased nitric oxide bioavailability, and as a result you have reduced vasorelaxation. So ultimately it's all about a balance between these two depending on the state. Sometimes you need to be inflammatory if you're sick and you need healing. Oftentimes you need anti-inflammatory is good for protecting you against cardiovascular disease. You don't want to be in an inflammatory state all the time. That's a HEP thing actually. So this is a summary side. You have endothelial cells here. You have vasodilators such as nitric oxide, prostacyclin, and EDHF, vasoconstrictors such as endothelin and thromboxane A2, just no endothelin, I'd say, most important. And endothelial dysfunction is an important biomarker of cardiovascular disease. Ultimately, it's a balance between the two. Veins and venous return, this is really short. As you can remember, capillaries are where the site of exchange of nutrients between nutrients occurs, and also where the site of exchange of waste occur. So nutrients will often go from the blood to the tissue, waste from the tissue to the blood. Venules collect blood from capillaries, veins return to the heart, right atria receives the blood returned to the heart. This is an image of the difference between veins and arteries. You can see there's a lot more muscle in this artery, smooth muscle. That's to allow it to be a high pressure reservoir, and the thicker walls made up of smooth muscle and less allowed to contract at higher pressures. As you can see over here, these arteries have higher pressures. Our veins, on the other hand, have much smaller smooth muscle walls and a more substantial adventitial layer. They're low pressure, they have quite low resistance, large diameters, thin walls, quite compliant, and one-way valves to prevent regurgitation, which can often, like gravity can pull it down. So you have one-way valves to prevent it going backwards. And these are low pressure symptoms, as this table shows you. Almost done. Venous return is influenced by 3 primary mechanisms, more than that, by these many mechanisms, but this is the 3 you need to know from the lecture. A pressure gradient is the most important one. So there's a pressure gradient between the veins and the right atrium. Right atrium has a lower pressure, which facilitates flow towards the right atrium. Important factor is that right atrium pressure decreases when you inspire, and so you have venous return during inspiration as well. The pressure of veins are determined by the venous volume and compliance of the veins, and sympathetic can affect compliance. So compliance is decreased by sympathetic response, which stiffens the walls. So just you need to know pressure gradient leads to venous return, skeletal muscle pump. So when your legs are contracting, you're pumping the veins to pump it up towards the thorax because it has to oppose gravity. And during inspiration, you don't need to know what a negative pressure is, but just know the pressure in the right atrium decreases, so it promotes venous return. Remember, always exercise increases venous return, and that allows you to have an increased cardiac output during exercise. This is just a summary of skeletal muscle pump, respiratory pump, and vasoconstriction, which is determining compliance. Not super high yield, I just thought I'd put in an image. Venous return ultimately contributes to end-diastolic volume, and stroke volume is determined by end-diastolic volume minus end-systolic volume. And cardiac output is determined by stroke volume. So ultimately, it's determining how much blood is being pumped out. So what venous return returns blood to the heart, increase end-diastolic volume, increases stroke volume, increases cardiac output.
Awesome. I will quickly whiz through HEP, just talking about the very, very, very not many high yield points. For thinking, you have two systems in your brain that at least Craig likes to term it as such. You have system one, which is your animal brain, focusing on fast, automatic, kind of subconscious, intuitive actions, fighting for survival. System two is like your more human brain, thinking, logical, reasoning, analytical. That's system two. When we're making decisions, we usually use both of these systems. In some decisions, like eating, system one wins. In other decisions, like should we buy this house, system two wins. In general, we can also use the utility theory, so greatest good for the greatest number of people. We have a framing bias as humans, in which the circumstances around the choice affect what we choose. Quite straightforward. If I said you have a 90% chance of survival versus a 10% death rate, the 90% chance of survival sounds a lot better, even though they're actually the same thing. In terms of cognitive biases, we have those 5 down below. Have a rough idea of what they are. They're quite straightforward in that they're very logical. You'd be able to guess it in an exam. Just read over to make sure you understand them. So confirmation is looking at new evidence to confirm what you already believe. Anchoring is when you're relying on pre-existing information to make decisions. Sunk cost is when you don't want to stop something because you're worried about the time and effort you put into it. Availability is just whatever information you have available makes you think it's that important. So for instance, I know hearing about the crisis in Kabul, I might be thinking that the highest number of refugees in Australia coming in is from Afghanistan, when in actual fact that might not necessarily be true, but it's just the information I have available. And stereotyping, we'll know what that is. There's something called the Dunning-Kruger effect, which is pretty much that people like to overestimate how good they are at things. And people who are bad at things, especially, A, really overestimate how good they are, but B, they're so bad they don't even realize how bad they are. That's just the Dunning-Kruger effect. It's when you're so bad, but you think you're good and you'll never realize how bad you are. Funnily enough though, the more you improve, the more you realize you don't actually know it. So this is what I find in med, I don't know, maybe there's the same, but the more you learn, the more you realize I literally know nothing as time goes on. Fixed mindset and growth mindset, just know that growth mindset is good. Embracing challenges, thinking you can change and develop, good. Random HEP facts that may or may not come up. Process, rewarding a process rather than outcome. So rewarding the child learning rather than the child's results is better for them in the future. Mental overload, the more busy you are mentally, the more things you have in your plate, the more things you're trying to remember reduces creativity. So during exam time, you're probably not that creative. We can have divergent thinking, which is when we see there are multiple solutions to a problem, or we can have convergent thinking when there's only one solution to one problem. And sometimes these can be true in different circumstances. When I'm measuring a pipe, there's only one length of the pipe. In exploring mindfulness, we can have open monitoring, which is just when you're sitting down and embracing all the different sensations coming at you, or focused attention, which is when you're trying to lead your attention to one thing in particular, like your breathing. All right, now I have a bunch of models that sometimes come up. The first model is Biggs' model of learning. Biggs told us that there are 3 levels. There's surface, achieving, and deep. Surface is just rote learning. Achieving is based on competition. So your rote learning stuff maybe, but you're also trying to be better than everyone else. And deep is you're trying to master a topic. There are some controversial studies that said that achieving kids actually performed better than deep because they were looking for the buzzwords on the exams, whereas the deep kids were trying to explain why you can't give certain drugs in certain areas when that's not as relevant. But yeah, studies are controversial. We're not exactly sure what's true. That was Biggs. Bloom's was like, I'm gonna have many levels. I'm gonna say that there are 6 levels of like learning and behavior. Remembering is just recalling. Understanding is when you explain it to someone. Applying is when you're using your knowledge. Analyzing it is when you can distinguish between parts. Evaluating is justification. And creating is when you're actually making something new. That was Bloom's. And Miller, the last model you kind of have to be aware of. Miller was like, let's simplify it a bit. Bloom's is a bit complicated. Let's say there's only 4. There's knows, so like knowing a fact, recall. There's knows how, so knowing like a process. So like knowing there are eggs is easier than knowing how to make an omelet. Shows how is like you can teach someone, and does means you actually do it. So shows how, like I can show the examiner how to wash my hands for hand hygiene, but actually washing my hands for hand hygiene when like the examiner is not there is a different thing. So that's the does. And last one, time management. There are some really famous people that said, like billionaires, that said that this is how they organize their time. They put their tasks into either important or not important, urgent and non-urgent. And there are some examples there of like what each of these mean. Pretty much is like the new way, like in the last 2 years, of like how to manage your time. And that's the one that Craig advocates for. So just having an understanding of that's how people organize their time. And that is it. Well done, guys. You made it. I'm proud.
Yes. So that was our last session of the year. So a lot of our regulars are here. So thank you so much for sticking with us the whole year. It definitely made it easier to motivate and continue going. We had a couple of people drop out, so we had quite a substantial workload, especially this semester. So yeah, your participation and always coming really helped us out to be motivated to do it. So we really appreciate it. We really enjoyed getting to have you all like participate and getting to know you, and hopefully we've helped you as much as possible. But yeah, thanks so much for your time and everything.
Thank you so much, guys. You guys have been absolute legends. We really appreciate your work.
Oh,
Thanks
thank
so
you
much,
guys. You guys kept us motivated, to be honest. So thank
Yeah.
you. Enjoy the week. Message us if you have any questions.
Yeah. Best of luck.
Yeah, good luck for your exams. And hopefully we'll see you guys at some point.
Thank you.
See ya. Thank you.
I'll stop it.
Yeah.